So the dentist has there's a lot of flexibility with the system. So in a given system, in a given case, the surgeon can either use the tube guide and forget about the ThinLayer guide. They can use the ThinLayer guide and forget about the tube guide. Or they could use the ThinLayer guide and not use the drill stops and center it in the guide hole if they like the feel of freehand drilling, but they want to be guided. So there's a lot of flexibility. Or, as I said, in a given case, it's possible that you could have the bicuspids with tube guides and then the molar next to them because of lack of vertical clearance. You would then use the ThinLayer guide for the molar. So we try to provide a lot of flexibility to handle most situations a surgeon would run into.
Okay, great. I think we could proceed.
The last case we'll show is a lower first molar, and this is flapless. So again, first we go to Blue Sky Plan implant planning software. You get the cross-sectional, axial, panoramic view and the 3D. It would size the abutment as a molar, 10 millimeters in this case, and use the abutment as a virtual tooth. In this case, we went to the cross-sectional view. We didn't have an opposing model, but we had a little piece of the opposing molar in the scan, and that enabled us to get some orientation toward the lingual cusp of that upper molar. You also can see faintly here the outline of the gingiva. So we have some sense of the depth of the gingiva over the implant. When you go into the 3D reconstruction, you can get an image, a 3D reconstruction of the patient's osseous anatomy. And if you toggle the density threshold, you can then get rid of the bone and see the roots of the tooth. And this is a very powerful tool. So you can see the relationship of your implant to adjacent roots. I might note that this menu here allows you to select a centered model, a model with markers, or the patient, or an articulated model, depending upon what has been scanned in. So you get this really enormous amount of enhanced aids for doing planning using Blue Sky Plan. So if you go to the 3D screen and you view model with markers, then you get the model with the marker indicating the ideal implant position. And then you can look at that and see if the center line of your implant is coming through the ideal insertion point. And you look at it from the buccal, you can look at it from the distal in order to get a sense of what your alignment is relative to the adjacent teeth. Then you can use the abutment as a virtual tooth. And then you do the case. And again, when we do the case, as review, we create a bleeding point. And that bleeding point is an insertion point analogous to the bottom of a tube. The ThinLayer guide that's placed at the occlusal surface level, that's analogous to the top of the guide tube. And together, sequentially, they define your implant trajectory. So we go in an angled entry. This is a first molar, and there were some vertical issues. Stand the drill up, go to depth. It was a flapless case, so we used a punch. Again, with each sequential drill, we did the same thing. Angled entry, stand it up, drop into depth, and you can see here the finished osteotomy with the guide hole from the ThinLayer guide. When you compare the tube guide to the ThinLayer guide, you can see the difference in that the stacking over here adds 7, 8, 9 millimeters vertical clearance. Here you go in at an angle, and you can see the relationship between the back of the handpiece and the teeth. Here we go in, and there's room to do it. Here, you have a problem. So when we take a look at the completed case, you can see the position of the osteotomy. The implant is placed through the guide hole, and if you look at the views on the bottom, you can see that this implant is placed in an ideal prosthetic position. I just want to make a couple other comments because I think we're pretty much finished with our presentation, Michael. But I just wanted to say that our goal is to make guided surgery a reliable and easy-to-use technology, which is readily available to the dental community. And I want to thank everyone for attending.
Can you go back to the pricing information so that the dentist could see what the costs are and what's included?
Sure.
And at the same time, if anybody has questions, please enter them into the chat box on the bottom right. And can you also provide mailing address to send models and an email address to send DICOMs?
Yes, Michael, if they could go to our website. Everything's on the website. GuidedSurgerySolutions.com is the website, and they'd find everything there.
Okay, fantastic. And I'll just reiterate some points I made right at the beginning. A recording of the webinar should be available online within a few days. The CE credits should be distributed via email within a week. Another comment that just came in now, if you could go over the protocol from the time the patient goes to your office to placing the healing collar.
Sure. It depends upon whether the doctor has a scanner in his office or not. It would be a different protocol. I can cover both. Okay.
Okay.
If a doc has a scanner in his office, then we recommend the following protocol, which is it's a wonderful protocol because it eliminates scatter as a variable in terms of the merges. What we suggest you do is, and we have an illustration, I think, on our website to do this. You place 7 fiducial markers on the back of a disposable impression tray. And then you take an alginate impression of the patient's arch, and while the tray is still in their mouth, you put them in your scanner. And you scan them with the alginate tray in their mouth. You then take them out of the scanner, remove the impression, and then you pour the model. When the model hardens, you do not remove the model from the tray. You scan the model in the tray, and then you can remove the model from the tray. And what that does, it generates 2 DICOMs, and those 2 files can be merged within Blue Sky Plan, but you're not merging on the basis of the anatomy of the teeth as you would if you did an optical scan. You're merging on the basis of those fiduciary markers that are present in both the model and in the patient's mouth when they're scanned, and the scatter does not affect them. They're too far away from everything for scatter to affect them. So that we call our scatter protocol, and we suggest, if you have a scanner in your office, that's the best way to totally avoid the issue of getting bad merges or being told you can't merge because of scatter. If you don't have a scanner in your office, then what you would do is you would take an impression of your patient's mouth, pour a model, send them out to be scanned, and send us the DICOM, or have the scan center send us the DICOM of the patient scan, and then you would send us the model, and we would scan the model for you. It's possible some of the scanning centers would scan the model for you, and then you would send us 2 DICOMs, and then you would have to send us the model also. In that case, the merge would be dependent upon the patient's anatomy, and if there was a lot of scatter, there would be a problem with the merge. But we have a solution for that in that using a vacuum-formed appliance with fiduciary markers on it, you can accomplish the same thing. You would make a vacuum-formed appliance with fiduciary markers on it, fiducial markers on it, and then you would the patient would wear that when they were scanned, and then you would send us the model with the little device with the fiducial markers on it, and then we could scan the model with that on it, and then we could merge on the basis of the markers. So we've developed a few scanning protocols to deal with these situations.
Do you want to elaborate on which situations the dentist has to be concerned about the scatter and the problematic merges?
Sure. That would be if there's a lot of crowns in the patient's mouth, or if there's a crown near the surgical site of interest. That could be a problem. And again, we could spend an hour talking about just scanning, because there are things that you have to be aware of when you scan these patients to minimize problems, such as separating the teeth, trying to scan one arch, things like that. Or if you have the option of removing a bridge and placing a temporary to get rid of the metal, that's often helpful.
And all these protocols are available on your website?
All the protocols I'm describing are on our website. But the scanning thing and scatter and how you do it is a very important piece of guided surgery, and that's a topic that really deserves a lecture unto its own, so to speak. It's a really important topic.
Okay, that's fantastic. I would like to thank you for this fantastic presentation. It's really informative and educational, and a whole new way of doing computer-guided surgery.
Thank you, Michael. And, anyone can email us with any questions. We're happy to, I think the one point I'd like to make about guided surgery, it's an educational endeavor. And I think, it's not taking a tube and just blindly drilling a hole through a tube. There's a lot to it. And I think that part of what I think, the dental community as a whole needs to do is to provide really good education as to what goes into guided surgery. And I think once that's done, I think then we'll see adoption rates increase quite a bit, and I think that's better for the dentist, and I think that's better for the patients.
Okay, well, two comments that just came in. One is if you could bring up the contact information again on the screen, and another comment is that they're looking forward to the presentation on scanning, so you could start working on your next lecture.
Be happy to do it.
Actually, multiple comments coming in about that.
Yeah, it's something that's not discussed enough. I mean, the cone beams are really relatively common now compared to a few years ago, and it's just not. I think we all need a lot more education about how to use a cone beam and what the variables are that affect the quality of scans, radiation doses, and those sorts of things.
Well, maybe we could follow up part 2 of your presentation.
Thank you. Be happy to.
Okay. Thank you very much. Have a good evening, everybody. Thank you for attending.
Thank you very much, Michael, for hosting us. Good night.
Sure. Good night.